My name is Dr. Gustavo Leibaschoff, and I will try to explain to you why biostimulation helps us in some procedures. In this case, we will talk about the use of fat tissue and PRP. This is a presentation under my intellectual property, and I appreciate that you take care about this. As you know, autologous fat transfer is very attractive because allows to us to increase the volume in the small or large volume. But the last research, and we will look about this research later, the most important today is the tissue regeneration. And this is very important to allow us to have results that you can see here in the breast, in the buttocks, or in the face of any part of the body. Also in gynecology, as you can see, a lichen sclerosus before and after 6 months through treatment with micrografting, nanofat, and PRP in a patient of 37 years old to recover the quality of life. So this is very important nowadays. But we need to understand, it's very, very short, this presentation, what is fat tissue? Because fat tissue is the most important endocrine organ in our system. So it's a complex mechanism of the extracellular matrix, blood vessels, fat cells, and a large of collagens and endothelium cells, stroma vascular fraction, and stem cells, adult stem cells from the adipose tissue. All of this is the adipose tissue, and this is important. And this is important because when you're working with adipose tissue, you know that in 1 gram of fat tissue, you have almost 5,000 stem adult cells. And if you make a quickly account, when you take 100 cc of fat tissue, you have 500,000 adult stem cells. And this is very important nowadays for the treatment and survival of the fat tissue. Because the fat tissue that we use, this is the normal tissue, and this is the problem. The tissue one go hyperplastic and hypertrophy go to fibrosis. And the fibrosis go with collagen 1 and collagen 6. They are very pro-inflammatory collagens. Come from the normal fat tissue to the fibrotic fat tissue, and fibrotic fat tissue, after the inflammatory process, lost all the normal metabolism of the fat tissue. So the function is not the same, and the result in our treatment is not the same, because it's not the same that in normal expansion. Normal expansion means hypertrophy and maintain the relation with the blood cells, 1-to-1 with the capillaries. But in the lipodystrophy, you have hypertrophy, and hyperplasia. You lose the relationship, you come to inflammation, you have more than inflammatory macrophage 1, and in the end you have more fibrosis and more insulin resistance. So this is very, very bad for our system with hypoxia, lost the angiogenesis, inflammation, and fibrosis. And this was very, very good study for this man, Dr. Philip Shearer, to working in the UT, University of Texas Southwestern Medical Center at Dallas, close to my office. And I have lucky because I am involved with him in some studies and some presentations, and I learned a lot about the new physiopathology of the fat tissue. And very short, this new physiopathology comes from the hypertrophy, hyperplasia, hypoxia, the presence of pro-inflammatory process, the presence of the macrophage pro-inflammatories, MA1, to go to produce the lipodystrophy with much fibrosis, a large amount of pro-inflammatory macrophage, hypertrophy and hyperplasia adipocytes, and many adipocytes are dead because lost the contact with the capillaries. And this is the lipodystrophy, and this is where many doctors, many physicians take or harvesting fat for lipografting. And more, when you have the dysfunctional adipocytes, the problem is the dysfunctional adipocyte produce some secretions to help the development of the cancer cells, also increase the number of metastases, and also dysfunctional adipocyte produce the inactivation of chemotherapeutic products. As you can see here, the dysfunctional adipocyte, so alteration in the lipid metabolite, inflammation. This is very important, inflammation, because we need to work against the inflammation, increase the leptin and decrease the adiponectin. This is the good guy in the movie. Alteration in the extracellular matrix and fibrosis. We need to work against the fibrosis as well. Problem with angiogenesis and the overexpression of aromatase for the hyperplasia and hypertrophy in the fat tissue to produce from the testosterone and the hydrotestosterone, you lose a large amount of estrone. And this is dangerous for breast cancer, for example. And all of these produce the promotion of the tumor growth and also the metastasis as well. So, one of the most important problems that we have in lipografting, when you have inflammation of the fat tissue, and sorry, this is in Spanish, I don't make the translation, but I will make now for you, is the inflammation inhibit the generation of the preadipocytes in the come from the stem cells. So when you don't have preadipocyte, you don't have differentiation of the adipocyte. So the dynamic of rotation of adipocytes in fat tissue are stopped. You don't have replacement for the old adult cells. So you inhibit the preadipocyte, and this is a very, very great problem because it's in relationship with the survival of the lipografting. So, you know, we have the normal adipose tissue or healthy adipose tissue with stem cell, progenitors, endothelial cells, adipocytes, you know, a large number, a good circulation as well. But when you have the injured adipose tissue, you know, necrosis, inflammation, disappear the progenitor cells, disappear the M2, is the macrophage anti-inflammatory. So there are a large alteration we need to correct if we need to go to survive. Another thing very important is the paper from Kotaro Yoshimura about what happened with the adipocyte and no vascularized fat grafting. When it's not vascularized fat grafting, it's the early death. And the adipocyte is replacement for fibrosis, but not for another adipose tissue. And you can see here, this is the study from Kotaro Yoshimura. This is the study. And you will see each fat grafting have 3 layers. One layer of 300 microns, where you have adipocyte and stem cells. The second layer is almost 1200 microns. You don't have adipocytes. You have only stem cells. And after all of this, all will go to death because don't have any support from the circulation. So you can see here, good replacement, and here from the regenerator from the stem cells, and you have another fat cell. But no, here you have the necrosis and oil cyst and cicatrization, but this is not good. So we need to increase the survival area. We need to increase the regeneration area. This is the challenge that we have nowadays to improve the result of the lipografting. Also, we need to improve the presence of the partial pressure of oxygen. How increase this area to survive? Because remember, when you talk about the fat grafting, it's not only a filler. We talk about the tissue revitalization. We talk about the tissue fertilization. We talk about the stem cells. We talk about the function and the quality of the tissue. Because nowadays, we use fat tissue and we use the stem cells with different pathologies that you can see, and we have a very good result with this. Why? Because it's bioregeneration, because it's biostimulation. But for this, it's not only important the presence of adipocyte, we need the presence of the stem cells. How we can stimulate the presence of stem cells and how we improve the presence of oxygen. Because when you have more oxygen, in the area 4 of the study of Kotaro Yoshimura, you have the area of survival increase the thickness of the area of survival of the grafting in the fat tissue. Also, when you want to improve the regeneration area to have more stem cells, okay, you need to have more capillaries in ground, more vascular connection, and more stem cells. Here it will be the action of the PRP, plasma-rich platelet. So oxygen, PRP, and we improve our quality, the fat grafting. Also the important, the plasma diffusion, and is in relationship with the concentration of the oxygen and nutrients. Again, the presence of oxygen and nutrients and the action of the PRP as well. What is PRP? You know very good. The first paper of Robert Alexander in 2001 talk about the importance of the influence for the adipocyte grafting with the use of PRP. And PRP not only working of the fat tissue, only working on the stem cells, adult stem cells, to improve and increase the number of them. There are very good studies from Dr. Valerio Cervelli about this. We know the platelets is a large and important cells to produce a liberation of different secretion, more than 800 proteins in liberation. But the most important for us, for the granules, is the growth factors. And you have the platelet-derived growth factors and the transforming growth factor alpha and beta. Very important beta, because beta is the key to stimulate fibroblasts to produce collagen, because without transforming ground factor beta, the fibroblasts don't produce collagen. So look, this is very important. Vascular endothelial growth factors, important for the promotion of the capillaries, and also important the inhibition in some treatment of cancers, the epidermal growth factor as well, and the fibroblast growth factor. You have insulin growth factor as well. You have a lot of growth factor to working over the stimuli endothelial cell growth, and working over the inflammation, attenuate inflammation cascade, and anti-inflammatory. This is very important, and stimulate the collagen and produce new cells. So, and repitylation, angiogenesis, this is very important, the function of PRP. But the question is how I obtain real PRP, because I use the normal tube. So it's important that you know the differential sedimentation. What is in the bottom, what is in the top? Because the density in grams for milliliters. So you can see the plasma is in the top and the red blood cell is in the bottom. So we need to know this difference, and because we can make the centrifugation, and in the end of centrifugation, we should know where in the bottom, where in the top, and we need to remove of this. But sometimes it's very difficult working like this, because you sometimes contamination with the blood. If you have contamination with the blood, the PRP really is not working well. So the good idea was create a tubes with a gel, a zerotropic gel, as you can see here, and this gel allowed to us to separate perfect the blood and the neutrophils from the plasma with platelets and monocytes. So we don't have problem with this. So when you have the gel, this zerotropic gel separation, you have the separation without problems, and the red cells and the granular cells are excluded and go to the bottom of the tube, and you have a very good concentration of PRP and large amount as well. So the process to obtain the PRP is, you take the blood, make the centrifugation, a special centrifugation, a special G, the special time, and you remove the plasma, okay, and put the plasma in the tube and push in the syringe, and it's ready to go, ready to use, and you have a large amount of PRP in your hands to work in your patients in different applications. So, and you can see we can have different tubes because it's small fat grafting or a large fat grafting that we need to go. And we have the amount of PRP that we can use in our patients, or inject directly, like a PRP, like a mesotherapy, or in this case, when we talk about the fat grafting or nanofat, we talk later, is how the PRP is mandatory today in the use of the fat grafting and nanofat. So another thing important when you use PRP, you need to know which is the concentration that you have, the amount of red cells, white cells, granulocytes. You need to know all this information, the concentration of plateletary growth factor, or vasoendothelial growth factor, or epidermal growth factor. You need all the study was done for the health authorities because you know you're working with real PRP and no is a yellow color inside of any tube. This is not PRP. So because not all look the same, and not all Markovitch. You know, there are many companies to produce different products of PRP, and in my opinion, there are very good difference that look why this Selenis is one of the best products that we can have to use like a PRP. More than this, there are many studies that provide that this closed system is very safe. It's sterile. You make in front of the patient. Immediately you use the PRP. There are no doubts about the blood if from the patient. And you know all the rapid process that you have for use this kind of product that FDA approval as well and CE approval. And you can use very safety. Closed system is very, very safety. You can use immediately in your patients. Also, like the FDA mark, again, the amount of PRP, the platelets, the concentration of red cells, white cells, concentration of the platelets, if this stable separation, yes or no, and the amount of growth factor that you have. This is a study from the FDA. And the other study, very interesting for me, is the study present from the INSERM in France from Dr. Magalon. He make a large study. This is only the one slide. But he, in the end of the study, he said, there are three into the 22 different trademarks. There are only 3 to have very safe to work in preparation of PRP. And these 3 have the gel. These 3 have the gel. One of these is Selenis, that you can see a few minutes. So PRP, how much PRP we need to add to the fat to survive the preadipocytes and survive the grafting. Ali Modaresi from Geneva Hospital say 20%. No more 10%, no more 5%. It's 20% minimum. And Ali Modaresi say that this add to PRP have several advantages: best fat graft survival, fever, bruising, and inflammation. Remember, we need to combat the inflammation. It's very important. And easier application because it's more liquid, the fat grafting because they add of the PRP 20% in this case. But there are papers from Dr. Valerio Cervelli from the University degli Studi di Roma, Tor Vergata, with Dr. Pietro Gentile. They are working a lot with the PRP and in combination with fat, a large amount of patients, Romberg syndrome, with a good result after 1 year. And another study about the use of, also the use of insulin growth. And you can see when you put fat with PRP in blue, fat with a stromal vascular function, and fat alone, you look the evolution after 18 months, and you can see with 50% of PRP in the fat graft is the large survival. We use 40%. 40% is no problem with the small fat grafting, but when you have large fat grafting, well, we need to take, if you want to have a good result in your patient and safety result in your patients, we need to say to the patient, well, we need to have 2 or 3 application, first at all. Second, don't inject more than 150 or 200, for example, in the buttocks. Remember, fat live in the fat. You need to have fat to leave the other part of fat. So please take care about this. And it's important, don't over correct a large amount because the fat go to die. There are no capillaries, there are no nutritions, die. Go to necrosis, go to oil cyst. And the presence of the PRP is very important. So you need to manage the amount between 20% and 40% of PRP. This is why Selenis produced this tube, a large tube, so you can find more amount of PRP in the good concentration without red cell, without neutrophils. So the experience suggests that the use of PRP increase the long-term retention of the fat cells, the rate of revascularization, very important, remember this, and the survival of the transplanted cells. This was a study was Robert Alexander and Sadati. So in the end, why I use PRP? And all the people today, if you want to work with fat, you need to use PRP. This is mandatory in my opinion. Increase the retention of the fat cells, increase the rate of revascularization in the graph in high volume transfer on a lower volume transfer, reduction the spherical calcification and the formation of lipid cysts, very important. And for me, the most important, helped differentiation of pre-adipocyte precursor cells into mature adipocyte. So recovery the pre-adipocyte. Remember, inflammation killed the pre-adipocyte. Well, with PRP, I have again pre-adipocyte precursors. So this is the key to retain the survival of the volume of the graft. This is the key. And this is the action of the PRP in this study. So you want to make, you have growth factor growth factors here, and you have working over the extracellular matrix. You need to remain the extracellular matrix very flexible for the life of the fat tissue. So you have more collagen, more glucosaminoglycans, more fibrinolactina working over the tissue maturation. How? Remodelation of the scar and fibrosis, working against the action of the metalloproteinases, for example, working over the mitochondria, working like an antioxidant, okay? And working against the oxidative stress, working over the angiogenesis, increase and induce the growth of new blood vessels, and working over the epithelization. All of this is the action of PRP. It's enough to understand this, but understand different papers that we have, that we know today that PRP is important in the biostimulation of all the tissues, biostimulation all the skin, and biostimulation and bioregeneration of the fat tissue in the fat grafting. So the survive depend of the new exchange with the extracellular fluid. You need to have a very good extracellular matrix, PRP. Normally, grafting is very hypoxy during period of time. It's 48 hours normally. And in these 48 hours, each fat cells produce, because the hypoxia, produce BCF-FG, so vasoendothelial growth factors to produce microcirculation around each fat cell. This is marvelous. The biology is incredible. But this is also helped with the PRP. and also increase the oxygenation. The oxygenation, in my experience, I increase oxygenation. I use before and after the grafting, I use carboxytherapy, injectable carboxytherapy, to increase the tissue oxygenation, vasodilation, increase the collagen and connective tissue, and clean the extracellular matrix. I told you to you it's very important, the quality of the extracellular matrix. So, a guideline, very short guideline of lipografting, selection where you put the fat grafting, pretunnel the area before placement the grafting. Remember the place where you placement the fat grafting, don't be infiltrated with liquid, so no local anesthesia. Don't put the adipose tissue grafting in areas with inflammation of compromised circulation. Years ago, we say don't place the adipose tissue in dermal plane on intra-injury scars. But now we say yes, you can placement there because we know today that we have a dermal layer of fat tissue, you knew this, and the action of the PRP and stimulation of the stem cells to recover the injury in the scars, for example. And you know, you find that aesthetic access opening in the area of the body to placement the fat grafting. Remember, use good cannulas, and the good cannulas for harvesting and placement are the same size. And this is one of the best cannulas. All the cannulas might be blunt, and multi-orifice, multi-holes, and you need to clean the fat grafting after you harvesting. You can talk different process, decantation, centrifugation. I prefer to use decanting. So many years I use decanting, and decantation with a sterile normal silent solution, and you need to use 4 or 5 times to remove all the lidocaine and the epinephrine from the fat tissue. And then you have, when the infranadat is transparent, clean, like a saline solution, you are ready to placement the fat. Before this, when you clean the fat, you add the PRP. Okay, after cleaning, after the PRP, add the PRP in the amount that you can choose, 20%, 40%, 30%, up depend the amount that you can take of blood. In a small aliquot, you put the fat grafting. In the tunnel, you make a pre-tunnel before, microcannula with minimal amount of pressure. Minimal amount of pressure. For this, you use small syringes, please. Small syringe, no more than 10 cc syringe. In the face, 1 cc syringe, and 3 cc syringe in the genitalia, for example. This is very important. And again, it's important to know the effect of the drugs. This is why important remove lidocaine, because lidocaine kill the fat cells. So we need to remove in the first hour, we need to clean all the lidocaine to avoid to lose the fat cells for our grafting. And what is nanofat? Nanofat is a new concept. In nanofat, there are no adipocytes. The only that we have in nanofat are stem cells from the adipose tissue. And these stem cells working in the regenerative aesthetic medicine. And when I say aesthetic medicine, don't confuse. All medicine are aesthetic. Aesthetic surgical process are aesthetic medicine, and the no surgical process are aesthetic medicine, and gynecology, aesthetic functional is aesthetic medicine, and surgical aesthetic in gynecology are aesthetic medicine. Aesthetic medicine is a concept. It's a concept to working in beauty and health, but it's not different medicine. And important to any process to involve aesthetic medicine include non-surgical and surgical process is performed by physician. Okay, this is very important. And remember, when you make fat grafting, it's very important how you take the cluster of fat grafting, and the cluster might be smaller, small grafting. And nowadays we have a new device, it's very simple device, to allow to us to work in very fast, blunt cannula, multi-holes, and this system allowed to us to work in very safe because we know all the time where is the cannula in reference to our guide, okay? This is very important, and we use our micro cannula, blunt cannula, okay? 50 millimeters below the skin, here you have the system, and use also a syringe to block each 3 centimeters. And I harvested the fat from the superficial layer of the fat, where is the more amount, or more richer with stromal vascular fraction and adipose derivate stem cells from the fat tissue. So as you can see here, and this allowed to me to use a large amount of stem cells or nanofat. In 2013, Tonar was the first to talk about the efficiency and safety of the nanofat in the skin aging. Remember, it's not fat transplantation, it's intradermal injection of emulsified fat suspension with a 27G needle to promote skin rejuvenation. But we use also nowadays, as you can see, for improve the result of our fat grafting. So what Tonard found was they found mesenchymal stem cells, and the name was nanofat derived stem cells. And there are many studies, many histologic studies, and many publications that discovered these nanofat derived stem cells. And we know we add to the adipose tissue with PRP, because PRP increase the amount of stem cells, and we have a regeneration of the collagen, elastin, extracellular matrix, and microcirculation. This is crucial to reverse the signs of the skin aging, as you can see. So, I take the fat. As you can see, when you have a lipodystrophy, a big amount of fat, you have fibrosis. Always you have fibrosis. So it's a lipodystrophy. This lipodystrophy affects the adipose cells biology. So alteration of the fat grafting. But if you add PRP, good PRP, remember, good PRP, if you increase the partial pressure of oxygen, you will have improved the result of lipografting. But if you add nanofat to your grafting as well, you have a better result to your lipografting. In the end, you have a very good result in your grafting for the patient. There are many studies, as you can see, and you can read, you can find in PubMed about all of this to support all about the grafting, the fat, the nanofat, and the use of PRP as well. And finally, thank you for listening to this presentation, and I'd like to finish with the words of one of my master, my teacher, Pierre Fournier. He said, it's not what's in your hand, it's what's in your head. And he said, No device is going to replace your talent and experience. Thank you very much for your presence here.